students, case-based approach to hemoglobinopathies. Our chairperson is Dr. Prantham Chakravarti, Consultant Clinical Hematologist, Kolkata. And our presenter today is Dr. Mrinalini Kotru, Professor Hematology, UCMS New Delhi. And we have 10 Spanish students. Dr. Tejas Vaibhav Chavan, second year PG, KVV Karal. Dr. Vineet Khotian, third year PG, FMC Pune. Dr. Shriya, second year PG, AGMC Agartala. Dr. Akansha, second year PG, AIMS Rishikesh. Dr. Vineet, third year PG, RM LIMS Lucknow. Dr. Nurain, PG, second year PG, TMH Mumbai. Dr. Shraddha, second year PG, GMC Jalgaon. Dr. Anvita, second year PG, TNMC Nair Hospital Mumbai. Dr. Sonal, third year PG, DMCH Darbhanga. And Dr. Ekta, second year PG, NMC Burganj. I welcome all of you to the program. And moderators are Dr. Prashant Joshi, Assistant Professor, Department of Pathology, AIMS Mangalgiri, and myself, Dr. Aparna Vinod, Consultant Pathologist, Government Medical College, Palakkad, Kerala. And our webinar hosts are Dr. Anita Burgess, Madam, and Dr. Sumit Gujral, sir. Few reminders. In case of any connection interruption, low or no sound, video freezing, video lag, kindly leave the meeting and rejoin with the same link. And if the problem persists, please check the internet connection. And please answer the poll questions, if any, by typing in the chat box. Please do not send requests for annotation to the presenter. You will see a small symbol like this. Please do not click on it. Few disclaimers and few more. And these are our upcoming talks. On 30th January, we have a lecture class by Dr. Kedar Gyodar, Normal Histology and Grossing of GIT. And on 1st February, we have a slide seminar on hemoglobinopathies. So with this introduction, I welcome Dr. Mrinalini Madam to start the session.
A very good evening, everyone. So today's talk is on case-based approach to hemoglobinopathies. And I will be taking you through the journey of diagnosis of hemoglobinopathies through 7 cases, and there will be some questions in between for the audience. So I would request you all to participate so that I can clear your doubts wherever it is there, right there during the presentation. And then later on also, if you have anything to ask, you can be free to ask me. So before I begin with the cases discussion, a brief overview of how to approach hemoglobinopathies. And in our previous sessions, Dr. Reena and Dr. Sunita all have discussed about the hemolytic anemias and thalassemias and hemoglobinopathies as part of hemolytic anemias. So when I begin with the case-based approach today, I would like to briefly tell you once again that hemoglobin disorders can be structural or quantitative. So structural means that there is an alteration in the amino acid sequence like we see in a sickle cell disease, or it can be quantitative. That means there is absent or reduced synthesis. So that happens in thalassemias, and both kind of disorders can result in or do result in hemoglobinopathies. And there's another disorder which is hereditary persistence of fetal hemoglobin. The slide, just a second, the slide is not moving.
You could have clicked in the center of the screen. Can you share the screen again? Minu, you're muted. You're muted now. Dr. Mrinalini, unmute. Dr. Mrinalini, you have to unmute.
ये करो ना.
Perfect. Perfect.
So now, I'm sorry for the technical glitch. So how is it picked up, these hemoglobinopathies? So there are two major ways in which we encounter hemoglobinopathies in our practice. One is incidentally they are diagnosed, and the other category is that they are symptomatic for hemolytic anemia, or maybe for some other issue which I'll be discussing briefly with you. So when I talk about thalassaemic syndromes, they can be very innocuous or asymptomatic as transfusion, which is hardly required, to a regular lifelong transfusion, which happens, and there can be an intermediate spectrum in between. And so you need to know what kind of disorders produce asymptomatic hemoglobinopathy or which produce a transfusion dependent hemolytic anemia. So there's a whole list of that. And why I tell you here in the clinical case-based approaches that no diagnosis of hemoglobinopathy is complete without knowing about the clinical presentation of the patient. So you always have to keep in mind before you interpret a HPLC report that what is the clinical presentation of the patient? Is it an incidental detection or an ANC screening, or there is a hemolysis which is going on, or the patient has a history of recurrent need for transfusion? So all this information you should be knowing before you make a diagnosis. So there are other consequences apart from this can be unstable beta chains, which also leads to anemia, then thalassaemic hemoglobinopathies. Then there is a reduced solubility, so it causes vaso-occlusive crisis, ulcers, and so many other things which happens in hemoglobin S and also in hemoglobin C, and obstruction in polymerization and crystal formation like in hemoglobin C. Then there is also another group of disorders in which there is an increased tendency for oxidation that leads to cyanosis, and that is called as hemoglobin M. And then there you can have a patient of a hemolytic anemia and you will not be able to diagnose it. And it is also not very easily picked up on a HPLC. But if you see a retic preparation, you will see that there are Heinz bodies which are formed, and it could be a case of an unstable hemoglobin. So there can be so many types of presentations of a hemoglobinopathy. So the correct diagnosis is utmost important. So clinically, as I told you, it is asymptomatic or symptomatic. And asymptomatic is important because of genetic counseling, especially in ANC patients. So when we talk about approach to diagnosis, clinical history, we go in this sequence whenever we are talking about approach. And let me tell you, we should never alter the sequence because that will lead to a misdiagnosis. So beginning with the clinical history, followed by a critical examination of hemogram with peripheral smear. Then if you have a hemoglobin electrophoresis and you don't have a HPLC, then knowing how to interpret a hemoglobin electrophoresis or a HPLC, and then you don't stop there. You always then follow it up with a family study. And in some difficult cases, we also need to do a molecular study to know for exact mutation. So in hemogram, what do we see? We see for presence of anemia or no anemia in certain heterozygous beta thalassemia traits. Then MCV, whether it is normocytic or microcytic. I'll tell you in my subsequent cases why it is important to know whether it is normocytic or microcytic. And also TLC, there is an abnormality, although it won't affect the interpretation of HPLC. So in thalassemia major, you have very low hemoglobins and the transfusion requirement is very high and regular transfusion. MC also same as the thal intermediate, but requirement of transfusion is much reduced compared to a thalassemia major. And in trait, you don't need any transfusion, but you will find a MCV which is low, and hemoglobin strangely may be normal in some cases. So whenever you're looking at the CBC, just don't stop at hemoglobin. You also look at the MCV to see for a reduction in MCV, because certain traits, the hemoglobin is normal. So we may miss a underlying hemoglobinopathy if we just look at the hemoglobin and not the MCV. So when you get a microcytic hyperchromic cells, iron deficiency is always on the top of the suspicion, because it is the most prevalent nutritional anemia. But thalassemia trait and anemia of chronic disorders are the other DDs. And how do we sort it out on just the CBC? I will discuss it through the case. So this is a smear of a case in which you can see that there are small cells. There are very small cells you can see. So there is microcytosis, there is polychromatophilia, and there is presence of these NRBCs. So this suggests that it is a hemolytic anemia. And when you see a hemolytic anemia, microcytic, in a microcytic background, so most likely you are dealing with a thalassemia. So this is a slide of a thalassemia major or an intermediate patient. Then this is another peripheral smear in which you can see that cells are mainly normocytic, but these are boat-shaped cells, and these are the sickle cells. So identifying these cells is very important, because that will help you pick up a sickle cell on just a peripheral smear examination, even before you have examined the HPLC. So attention has to be paid to the presence of microcytes, especially in sickle cell, because if you have a compound heterozygous state of sickle with beta, you will get a microcytic cell along with the presence of sickle cell. So these little observations in your just routine CBC and hemogram will help you make a clearer diagnosis when you interpret a HPLC. So this is the retic preparation, and in current days we rely very heavily on automated retics and everything automated, and do not take care of the manual methods. And there is a value of manual retic in case of hemoglobinopathies, because there are two findings which are picked up in the retic count, which is the golf ball inclusions and the Heinz bodies. So Heinz bodies you get characteristically in G6PD deficiencies and unstable hemoglobins, and this is a very characteristic appearance of a golf ball inclusion, which you see in alpha thalassemia. So with this background of knowing about, yes? With this background of clinical history and hemogram, we should go ahead and interpret hemoglobin electrophoresis and HPLC. So this is very characteristic beta thalassemia trait in which you see microcytic hypochromic cells, and there are large number of target cells and very minimal poikilocytosis. So this is a very nice feature to pick up and distinguish beta thalassemia trait from iron deficiency anemia just on morphology. This is a hemoglobin electrophoresis characteristic plate. So this is the normal control or A2 control, positive A2 control. And I'll just explain you how you see a hemoglobin electrophoresis. So this is the origin. Here you get the A2 band, and here you get the HbA. This is the positive HbF control, and you see that HbF stops slightly before HbA. And this is how a normal, this is a hemoglobin hemoglobin electrophoresis of a normal person with a very less A2. This is a case of a beta thalassemia trait in which you get a prominent A2 band, and that we put as a control. So when we interpret HbA2, we see it in reference to this control. So apart from HbA2 and HbA and HbF, we have other hemoglobinopathies which are picked up. So HbC, E, and O are they all elute with A2, and there is a SD region just before HbF, and here you have S, D, and G, and Lepore and Q India which elute. And that is how we can pick up on basis of just this simple technique so many different kinds of hemoglobinopathies. So there is another type of hemoglobin electrophoresis that is acidic, and that also is able to distinguish various kinds of hemoglobinopathies, but not very popular. Then coming to the most popular and currently most useful technique, that is HPLC, in which we are able to also quantify and clearly see where the relative various hemoglobins elute. So this is a characteristic chromatogram of a HPLC, and here you can see that this is HbA and this is HbA2, and these are some non-specific peaks which are coming. And when the peaks are less than 6%, you can ignore them. The other thing when you see a HPLC is that you look at the total area. So it should be between 1 to 3 billion before you can start interpreting. And this should also be almost in the baseline. So when you have these 2-3 quality checks, so that means your HPLC is good for interpretation. So apart from this HbA and HbA2, you have other HBs which are eluted. So let's see that. So here is HbF, this is HbA, and this is HbA2. And these are distinguished on the basis of the retention time. So this is the retention time. It means that how much the HB is eluted, at what time it is eluted in the HPLC column. The first to elute is just a second. The first to elute is HbF, followed by HbA2, and then A, and then HbA2. So HbF elutes at 1.1, followed by A, which is at 2.5, and A2 at 3.6. Then we have HbD, which is at 4.1, HbS at 4.5, and HbC at 5. So you should be remembering roughly the retention time of these important hemoglobins, because Biorad gives you the complete description, but the Biorad variant, this is about Biorad variant 2, but D10 will not give you, and there are other HPLCs which may not give you. So you should be knowing roughly what the retention time is, because it is on the basis of the retention time that you are able to distinguish and identify the HPLC. So apart from these, you have P2 and P3 window 2, and this also you need to identify. So why is it important? Because in P2 window, apart from so many hemoglobins, we have glycosylated hemoglobin. So if you are watching a HPLC of a diabetic, so and you don't know about it and you are getting a P2 peak which is high, more than 6%. So you first need to rule out diabetes before considering other hemoglobins. Then in P3 window also you have so many hemoglobins which elute, and one of the most important ones in India is J-merit. So this is how, when you get acquainted by all these, you will be able to put it into your practice. So you should be remembering and trying to fit it into your HPLCs when you are trying to make a diagnosis. So now the quiz question. So you have to interpret it. This is a CBC and HB electrophoresis of a 24-year woman who had come for an ANC workup. So for your aid, I'll just tell you that hemoglobin was 9.8, 9.9, MCV is 61.9, RDW is 15.3. And this is the lane which you need to interpret. So I'll give you 20 seconds, and then all the audience can write the answer in the chat box. So shall I, Dr. Prantar, can you tell me? I cannot see what the students have written. Aparna?
Hi, ma'am.
Moderators will do it. Yeah.
Beta taltrate is the most common answer.
Okay, so that makes my job so easier. That means you all have now understood how to be HB electrophoresis, and this is a very, very good observation, and you should be skilled enough to understand that this is a prominent band. So this was the HPLC of this case, and you can see that HbA2 is 5.8, and value more than 4% is diagnostic of beta thalassemia trait. So coming to the case which I had given you, so I would ask Major Dr. Vineet to discuss it. So Dr. Vineet, this is the CBC which I had given, a 25-year-old male. So can you tell me the salient points and what is your interpretation on the CBC?
Obviously, for gender and age, the hemoglobin is decreased. Hematocrit seems fine. RBC count is increased and MCV is reduced. So it's a microcytic picture, and also MCH is reduced. MCHC and RDW seem to be fine. So there is minimal poikilocytosis.
Okay. So
And
does it help you with
percent is,
anything?
yes, ma'am. So from the Coulter report, from the parameters that are present in front of me, I can derive a Mentz's index, and it is less than 13 because of the low MCV and the increased RBC count. So it points towards possibility of beta thal trait.
Okay, so this is the HB electrophoresis, and you were supposed to interpret lane 1442. So what is your
Yes, ma'am.
interpretation?
So in 1442, obviously HbA is present in significant quantities. Also in the HbA2 area, there is a slight increase. So from this, my interpretation would still point towards a beta thal trait.
Okay, very well. So what is you have interpreted the HB electrophoresis. So
Yes, ma'am.
then I had also given you HPLC of patient and the sibling. So this is the HPLC of the patient. So what is your interpretation?
So, ma'am, in this, the HbF percentage is within normal limits, but A2 is more than 4%. So
Okay,
again,
so
HPLC points towards beta thal trait, and HbA is, although the percentage is not given from the chromogram, we can see that HbA is obviously close to 90%.
is present. Okay,
Yes,
and there are no abnormal peaks.
there are no abnormal peaks, ma'am.
Okay, so this is confirmed beta thalassemia trait.
Yes, ma'am.
Okay, so what about the siblings? So I would ask Dr. Akanksha to interpret the HPLC of the sibling. Thank you, Major Vineet.
Thank you.
You were correct in your interpretations. Dr. Akanksha, could you interpret the HPLC of the sibling of this patient?
Yes, ma'am. The HbF of the patient sibling is raised 93.7%, and HbA2 is 4.4. So, according to that, it will go into the beta thal measure.
Okay. So, so what is further you would want to do in this case?
Ma'am, in sibling, we'll go for the transfusion, and we can do a
Anything
chelation
to do
therapy
with the
also.
diagnosis? Are you okay with the diagnosis? You and 100% are you sure, or you would want to do something more for this patient to confirm diagnosis, or is it just okay?
Mm. Well,
Okay, fine. So, coming again to what was being discussed, everything is fine till now. Like you have diagnosed it correctly, that how you pick up the salient points. There is increased RBC relative to the decrease in MCV. That's a very important pointer for a hemoglobinopathy. And then Dr. Vineet had identified that there was minimal poikilocytosis, which also goes in favor of a hemoglobinopathy. So correctly, he picked up a prominent band in HbA2, and in HPLC also there were, when you look at the HPLC, just don't look at the A2 concentration and the F concentration. You also need to look at the graph and see whether there are any abnormal peaks here. So there were no abnormal peaks and the HbA2 concentration was raised. So that means that this is a heterozygous beta thalassemia. So then HPLC of the sibling, and if you look at the HPLC of the sibling, there is 93.7% HbF, and there is hardly any HbA, and there is this pre-integration peak present here. And this is a peak of bilirubin, which is present, which also suggests that patient has some hemolysis or indirect hemoglobin of bilirubinemia. So one of the people, I think Dr. Sanjeev, said that it could be a hereditary persistence of fetal hemoglobin along with trait. Well, it could be, but that is where the value of history comes into place. And here we are also seeing the bilirubin. So if we look at the isolated graph, there are two diagnoses in this case. One is a homozygous beta thalassemia, and the other is hereditary persistence with beta thalassemia trait. And to support homozygous beta thalassemia, we have this bilirubin peak. So that is why I asked you that what is the further management, and the further management is to look at the HPLCs and the CBCs of the parents. So that will complete the diagnosis. So here the parents CBC showed microcytosis with a high RBC. Both mother as well as father RBC is 7 and MCV is 6.64.1, and just look at the hemoglobin, that is 13.8. So anemia is not the only 100% seen in all hemoglobinopathies. You also have to look at the other indices. So then the HPLC of both parents was done, and both had beta thalassemia trait. So that is how we can say that this is a case of a homozygous beta thalassemia. So when you look at any HPLC, you should always also know about the clinical history of the patient, and when you have a abnormality, always do a family study. And before doing all this, also always rule out that the patient has received any blood transfusion or not, because that is going to alter your HPLC. So coming to the case 2. So this is a 7-year female referred for investigation of anemia, nutritional and query nutritional, and had received 1 unit of blood transfusion at 5 years. She has marked pallor. So Shreya, could you discuss the CBC for me?
Ma'am, the hemoglobin is reduced and hematocrit
Yes.
is raised. Normal RBC, MCV is reduced, and MCH is also reduced. And in the blood
What about
picture, we can see anisopoikilocytosis with many target cells, and NRBCs can also be seen.
So what does it suggest? Just the CBC?
Ma'am, by looking at the blood picture and the CBC, it could be a hemoglobinopathy rather than a nutritional deficiency.
Yes. And also the patient has received 1 unit of blood
1
transfusion.
unit. Yes, ma'am.
Okay, very well. So coming to the HB electrophoresis, you had to interpret 1183 lane. So what did you see in this lane?
Ma'am, in this, the HbA2 and HbA2 is raised. So,
And this is
ma'am, HbF.
okay, very well. So what is your diagnosis?
Ma'am, it could be a beta thalassemia intermedia or major.
Beta thalassemia. What did you say? Beta thalassemia. And what is the other thing you said? Okay, so Ekta, can you do you agree with this, or do you have an alternate diagnosis before I discuss?
I agree with her finding of CVC finding, peripheral blood finding, and electrophoresis. My diagnosis is beta thalassemia major, according to the
Major.
major. Yes.
Okay. Okay. So let us discuss it. So if you look at this electrophoresis here, beta thalassemia trait, I had told you HbA2 is high, but this is extremely high. This is at least 3 to 4 times higher than what is present here. So very high values of A2 are not seen in beta thalassemia trait or major. And HbA is totally absent here, and what you are getting is HbF. So HbF you are getting, and a very high hemoglobin which is eluting in HbA2. So can you still think of something else apart from thalassemia major? Anyone? Noor?
Ma'am, can it be an HbE disease? Like if it's
HbE disease? You are closer, but HbE disease is asymptomatic. And clinically, this is a severe anemia which has required at least 1 or 2 transfusion.
Ma'am,
And
can it,
HbA is very high. हाँ बोलो.
ma'am, can it be HBC with beta thal? Because
Okay, so
it
you
has,
think HbC.
yes, ma'am.
Is
Because the,
HbC very common in India?
no.
HbC is not common in India. So this brings out a very important point that we also need to know that where this patient is coming from. So some hemoglobinopathies are prevalent in certain geographical areas. So you need to know about that. HbC could very well elude here. You're right. But it is not very common in India. So you would want to know from where the patient belongs to. Okay, so that is a very important part of this, but due to so much of intermixing of races, may not find very good answers. But still, at least you should be knowing, and C is not very common. So HPLC here. So can you tell me, Anvita, that what is the interpretation of HPLC?
Ma'am, in this, A0 and A2 are raised. F concentration, HbF concentration is raised. Um, so it can go for beta thal trait.
No.
F and A2 are raised.
Beta thalassemia trait is asymptomatic. This is
Yes.
symptomatic. So when I tell you about case-based approach, I began with clinical history. So now what do you want to know? In my earlier slides, didn't I tell you that there are multiple hemoglobins which elute at different zones? It's not just A2 which elutes at A2. And similarly, the same is in HPLC also, that in A2 region, apart from A2, we have other hemoglobins which are also eluted, and you need to know about that. So what is noteworthy here is that there is no HbA. It's totally absent. We only have HbF and a hemoglobin in HbA2, and it is not beta thalassemia trait, because in beta thalassemia trait, HbA2 does not go beyond 9%. Mostly, maximum has seen is 7%, but still the literature says that till 9% you should be considering heterozygous beta thalassemia, and this is 62.7%. So that means we are dealing with some other hemoglobinopathy. Okay. So now let's look at the HPLC of parents. So this is father. Here the HbA2 is 25%. So Shraddha, with the HbA2 of 25%, is it a heterozygous beta thalassemia?
Yeah, it's a heterozygous.
It is. I just told you that heterozygous beta thalassemia does not go beyond 9%. It is 25%. So this is, mother is heterozygous beta thalassemia because her A2 is 4.5%. But father is not a heterozygous beta thalassemia. He is HbE trait or heterozygous HbE. Okay, so what is the diagnosis now? It is double heterozygous HbE beta thalassemia. So that is why this patient is presenting with a transfusion requiring anemia or a thal intermedia clinical phenotype. Thal intermedia is a clinical word. It's not a word based on the genotype. So clinically requiring a hemoglobin, a blood transfusion off and on is a thal intermedia. So this is HbE thal. So that is why family studies are important, and just in isolation, you cannot interpret a HPLC. So the diagnosis is double heterozygous EB thalassemia. Then coming to case 3. So Weber, will you discuss it?
Yes, ma'am.
This is a case of a 35-year female with weakness.
Yes. Ma'am, HB is mildly reduced. RBC is normal. MCV is reduced. MCH is reduced. And retic count is normal, ma'am.
Okay, so anything you can pick up from here? Can you suspect a hemoglobinopathy in this?
Yes, ma'am. Likely thalassemia.
Why? What is a clue in which you can say that there is a hemoglobinopathy?
MCV and RBC ratio is
Yes,
less than 13.
very well, very good. So this is the first thing which helps you suspect that you are probably having an underlying hemoglobinopathy, especially when the clinical history is almost asymptomatic. There is nothing
Yes,
very major about it. Okay, so you have to look at the CBC critically to ask for a HPLC. So then I had given you this HB electrophoresis and you had to interpret this. So what is your interpretation, Weber?
E, I think, is HBE
So
is related.
HBE heterozygous or homozygous?
Homozygous, ma'am.
Why do you say homozygous? And anyone else? Noor? Are you agree? Noor? Ekta? So, well, it is homozygous because what you are seeing is that there is hardly any HbA. So, all the hemoglobin which is present is only HB in eluting in HbA2 region. So, let's look at the HPLC. So, this is the HPLC and A2 is 84.2%. So,
It is
uh,
elevated, ma'am.
so yes, Weber?
It's markedly elevated in HbA2.
Yes, markedly. So this is, and there is no A. So this is homozygous HBE disease and it is asymptomatic. And the patient has microcytic hypochromic red cells. So when you look at the hemoglobins which are eluting at HbA2, apart from beta thalassemia trait and HbE, we have two other hemoglobins which are eluting in this region. So you may ask me that why I did not make a diagnosis of HbD Iran and HB Lepore, because they also elute at this region. So, for answer to this question, I would like you to have a very good look at this table. So, if you look at this table, so there are various quantities of HbA2 which are given. And when it is the normal HbA2 is between 2 to 4%. And if it is less than 2%, then you should start suspecting alpha thalassemia. 3.6 to 4% is a borderline A2 value, and you need to rule out megaloblastic anemia, hypothyroidism, and antiretroviral therapy, and also some other mutations in beta thalassemia, which are silent mutation. And this group requires the maximum, this is the group which requires molecular studies for diagnosis. Most of the beta thalassemias come under this range of 4 to 9%, and till 15%, 10 to 15%, we have Lepore trait, and 22 to 36% we have E trait and Lepore homozygous, and between 38 to 48% we have D Iran trait. So you need to be acquainted with the various percentages of HbA2 before coming to a diagnosis. So 38 to 48 we have D Iran, and 10 to 15 we have Lepore trait, and in between we have HbE trait. And homozygous condition of 70 to 90%, we can have any of these. And to make a final diagnosis, you need to do, what do you need to do? How will you make out whether it is homozygous E or D or beta homozygous? Anyone?
Pick in
Study
A2.
of the what? We can simply study the parents. So if they are E trait, both of them, it will be homozygous E. If they are D traits, both of them, it will be homozygous D. Homozygous beta will definitely be symptomatic, so that will not come under the differential diagnosis. But if you don't know the history, then of course you will make that mistake. So that is why whenever you are interpreting, I tell you again and again, you have to take into notice all these points. So coming to the quiz question. So this is a 27-year male asymptomatic with no organomegaly. And this is the hemogram in which HB is 14, MCV is 88, and RBC is 4.36. So everything seems to be normal, but incidentally, HPLC was done, and this is what the HPLC is. So I give you 30 seconds, so you can write in your chat box.
Even the participants, delegates who are there, they are invited to answer in the chat box.
So I think, Dr. Aparna, can you tell me what is the most common
Majority
answer?
answer is HBD Iran. Then some have HBD Iran. Then HBE, HBD trait. These are the answers. HBD.
Okay. So, as I told you just a few slides before, knowing the percentage of HbA2 is very important and critical for diagnosis. So here the A2 value is 40.1% and it comes under the range of HBD Iran. So the diagnosis will be heterozygous HBD Iran because you also have HbA along with it. So you have two hemoglobins, A and HBD Iran. So this is heterozygous HBD Iran, and this is also asymptomatic. And HBD Iran elutes in the SDG region on electrophoresis. So that is another way in which you can sort out the dilemma. So sometimes people do recommend that when you have a problem, you should put in a plate, a HB electrophoresis plate to double check because LEPOR and D elute in this region. So that is how you can sort the problem, this region. Okay. So whenever you are having doubts, it is always wise to do a assessment by the other technique, which is HB electrophoresis, and that is precisely the reason why I am showing you HB electrophoresis when HPLC is more precise and more popular. So the co-elutes are HB, LEPOR, E and D, and they are distinguished on the basis of the percentages. Okay. So this always you need to remember. One more thing I just saw was somebody had written HBD only. So we have another hemoglobin which is HBD Punjab. So that elutes in a different region and not here. So it is important to mention that it is HBD Iran. So coming to the next case, which is a female with weakness in And I would request Dr. Vineet from RML to discuss this case. Dr. Vineet?
Yes, ma'am. Okay, there's a 10-year-old female with presents with weakness and abdominal pain with a hemoglobin of 10.5, and she has a normocytic, almost normochromic picture and decreased red blood cells, and a reticulocyte increased reticulocytes on the peripheral smear.
So on this CBC, does it tell you anything that you are dealing with a hemoglobinopathy? You can say no also.
I would not guess from this, ma'am. Actually, not.
Yes, precisely. It is just fitting into the picture that HB is low, RBC count is also low, and hematocrit is also low, which is similar to all other kinds of anemias. And this is normocytic normochromic anemia. That's all you can make. So obviously in a normocytic normochromic anemia, you look at the peripheral smear. So is there something you have observed in the peripheral smear?
Yes, ma'am. We can see fair number of like the RBC density is decreased, and we can see fair number of sickle-shaped cells in the smear, and also increased polychromatophils.
Okay. So is there a diagnosis you have come to? Any diagnosis now you can make?
I would think of in terms of sickle cell anemia, but I'm not sure about whether it's a trait or a homozygous state.
Okay. So does the history of abdominal pain help you?
Yes, ma'am. It pushes me in the direction of a homozygous trait, because abdominal pain can be caused by vaso-occlusive crises, and it can cause ischemia in the
But
organs.
you
So that
still
can cause
can't be
abdominal pain.
sure about. Okay. So this is a solubility test. So can you interpret it?
Yes, ma'am. In the solubility test, we basically cause hemolysis, and if the solution turns turbid, then it's positive for the patient, which in this case is positive as we cannot see the lines through the test tube in which the test sample is obtained. So the sickle solubility test is positive in this case. That means sickle hemoglobin is present.
Okay. So do you think HPLC is needed now?
I think I would need it, ma'am, to ascertain whether it's a trait or a homozygous state.
Very well. That is the kind of answer I was looking for. So this is the HPLC. I had not given you the HPLC, so I'm showing it now. So now can you interpret it for me? Do you think
Yes, ma'am.
it is homozygous or heterozygous?
Based on this HPLC, ma'am, it's a homozygous state of sickle cell anemia.
What? Why did you call it homozygous?
Because ma'am, the HPS percentage is 72.1%. It's a huge peak at HPS, so I think it's a homozygous state.
And what about HbA?
And there's practically no HbA in the.
Yes. So is there some other differential diagnosis? Ekta, can you think of some other differential diagnosis? Or are you 100% sure it is homozygous HPLC? Ekta?
I agree with the diagnosis, ma'am. It is a sickle cell anemia disease.
Okay. So then I'll ask you, can it be a heterozygous HBS beta thal? It will also won't have HbA values, and it will also have a HbF peak and a HbS peak. So can you think of that as a differential?
I don't think in this case, ma'am, because the A2 levels is 2.5%. There shouldn't be
Very
more than.
nice, very good.
3.9.
That is the answer I was looking for. HbA2 is normal. In this case, it is not, and heterozygous will have a HbA2, which is on the higher side, more than 4%. So it is quite low, so we will not be thinking about that. But still, certain mutations do give a normal HbA2. So it is always wise to do a family screening. Okay. So that is why I said that all these go hand in hand in a stepwise manner. Although HPLC is very accurate, but still it needs to be supported by other things. So this is the CBC of the mother, which is showing anemia and a normocytic normochromic anemia. And this is the HPLC. So if you just look at the percentages, you cannot make a diagnosis. So looking at the graph, there is a peak at 4.36% retention time in the S window, and it is 37.9%. So now what is the diagnosis, Shraddha? Diagnosis of the mother.
I can't get
I
it.
again repeat, there is an abnormal peak here.
Heterozygous.
And heterozygous what?
Yes, ma'am. Heterozygous.
HBS. Yes,
Yes.
HBS, heterozygous HBS. So
Yes.
mother is heterozygous HBS, and on HB electrophoresis, the is coming in the SDG region, so that confirms it. Like, it's another supportive thing. So it is heterozygous HBS, and the father also is having the same picture. So both the parents are heterozygous HBS, and that confirms our diagnosis of homozygous sickle. So coming to the next question, quiz question. So you quickly, I'll just give you 10 seconds for this. You just have to interpret the test. Only 10 seconds, because otherwise we will not be able to discuss much. Dr. Aparna, can you tell me what is the most common
Sickling test positive. Sickling test positive.
Very well, very well. So this is how a sickling test positive looks like, and you can see these sickle cells. So sickle cell trait will maybe require more time to show this test positive. Homozygous sickle will come positive in a shorter time. So that is one hint you can get just on doing the sickling test. So coming to the case number 5, and this is the last case which I had given to you for interpretation. So this is a 25-year ANC patient with recurrent abortions. And Noor, can you discuss it with me? Noor, are you there?
I think she's
Anvita,
left,
you
ma'am.
can. Okay, Anvita.
Ma'am, by the seeing the hematogram, it's almost normal everywhere. HB is normal. Indices are
Yes.
normal limit. RDW is slightly raised. Platelet count is normal and retic is also normal.
So it seems totally non-suggestive of anything.
Yes, ma'am.
But since the patient was an ANC patient and ANC screening program is done in our institute, so and this is the peripheral smear. So this is also of not much help.
Yes, ma'am. In this, some few target cells are seen, and otherwise the RBCs are normocytic now. Few microcytic are seen RBCs.
Okay. So now this is the HPLC. Can you tell me what you can
It-
see? Or what is your diagnosis?
Ma'am, in this A2 is normal range, and HBS is raised. So maybe it's
HBS. So this is why I had given this graph and had cut all the other paraphernalia for you to understand that you have to look at the retention time. So it is 4, almost 4. So HBS comes at almost 5. So this is in a different window. This is 4, almost 4. So what hemoglobin comes at this window?
HBD by Punjab.
D Punjab.
D
Yes.
Punjab.
D Punjab.
HBD Punjab comes in this window, and this is how the printout comes on the HPLC. So you don't have to remember exactly, but still it is always good to know where the different hemoglobins elute. So this is HBD Punjab heterozygous, because we are getting a percentage of 37.7, and there is also HBA, heterozygous HBD. So coming to the quiz question, a quick small question. 11-year girl with weakness and delayed milestones, hemolytic facies and splenomegaly. Hemoglobin 8.3, RBC 4.6, MCV is low, serum iron is also not low, transferrin saturation is on the higher side, and the HPLC is this. So I give you 20 seconds to answer. Sir, how much time do I have? Can I take 2 more cases? So, Dr. Aparna, can you tell me what is
Yes,
the
ma'am.
most common
Answers
diagnosis?
coming up are alpha thalassemia, HPH disease.
Very good, very well. So, the clue lies here, first of all, in the history, that it is a history of a hemolytic anemia, and that also a hereditary hemolytic, congenital hemolytic anemia, and it is microcytic hypochromic in nature, and HbA2 is very low, less than 2%. I told you when it is less than 2%, you should suspect alpha thalassemia. And then if you look at the graph, you see two peaks here. There is this M pattern, and this is HBH and HB bars. So HBH disease shows this pattern, a characteristic M kind of a pattern, and that is what is important to look at the graph as well. So HbA2 low, and with this kind of a graph, you should suspect a HBH disease or alpha thalassemia. So very well, I'm quite happy you all made it. So another thing in retic inclusion, there are these gall ball inclusions, and you should, for your own curiosity, you should always see the retic preparation and incubate for a longer period, and you might see these gall ball inclusions.
Yeah,
So,
I have a
Aparna,
question
Dr.
for the
Aparna.
students. Sorry, Mrinalini,
Yes, Doctor.
I have
No
a question
problem,
for
sir,
the
please.
students. Yeah. So there was this peak in the earlier case, right? But why the output show it? Any student can volunteer to answer. When you diagnosed it at a hemoglobin H, there was this peak, right? But why was it not there in terms of the output? P1, P2, or anything unknown peak, it said nothing. Why?
So because
Sorry?
it's in the pre-integration window, sir.
Yeah, so you always have to remember in an automated HPLC, there's an algorithm which integrates from a certain point, and it was pre-integration. So madam told you that other than looking at the output of the numbers, always look. Thank you. Yeah, Mrinalini, you can proceed, please.
Dr. Prananda, should I discuss 2 more cases? Because because 1 hour is over. Should I discuss 2 more?
Of course, of
Like,
course.
Quickly.
Please go
Yeah,
ahead.
yeah, please. Go ahead.
Okay. So coming to the next case, I'll quickly take up these 2 cases. This is a case of a 30-year-old primary gravida attending a AS clinic and anemia referred for investigation. So the point here again is that this patient seems to be relatively asymptomatic. And this is the hemogram of this patient, and HB is low and there is microcytic hypochromic anemia, but RBC count is not very high. Unlike we see in characteristic hemoglobinopathies like beta thalassemia trait. Nonetheless, there was this abnormal HPLC which was there, and there was this peak of 18.2% unknown peak at a retention time of 4.72. So now how do we deal with this? So HPLC is not giving us any hints that whether it is a D window or a S window or a C window. It is just telling us it is an unknown peak. So should we ignore it or should we start understanding
It's
it?
significant that unknown window more than 10% is considered as
Yeah.
significant.
Yes,
to
exactly. So
evaluate.
more than 6%, they say we should not ignore those at all. So retention time of 4.7. So you need to refer to your books that what are the hemoglobins which are eluted at retention time of this and what are their percentages. So in India, we have Q India, which includes a retention time of 4.6. So that is how this is Q India, and the percentage also fits into a alpha chain hemoglobinopathy. So it is 18.2%. So looking at this, we can make a confident diagnosis of HBQ India heterozygous. The other way of also confirming it is by doing an electrophoresis. And I told you another technique when you are in a problem will help you sort it out. So HBQ India elutes in the SDG region. So it eluted here. So that confirms that what hemoglobinopathy, unknown peak we are dealing with is HBQ India. So that is how we approach one by one different cases. So coming to this few takeaway points from so far what I've told you, that history of blood transfusion always needs to be taken because it will give you a peak in the HbA region and which will confuse you in interpretation, and the quality of sample needs to be assessed. And I told you that you need to look at the area under the curve, 1 to 3 billion, then a straight line, almost a baseline straight line when you're assessing the HPLC, and noting down the values of A to A and F, and then also looking at the presence of any abnormal peaks. And you do not have to stop here, and you always have to do a family screening. Okay. So coming to the last case and the final case of this presentation. So this is a 35-year male, and this had come in our ANC screening program, and the wife had been picked up as heterozygous beta thalassemia. So we had to do a screening of the husband, and this is the hemoglobin 12. MCV is normocytic normochromic, and it all looks perfectly normal. So the smear also doesn't show much except a little bit of hypochromia. And this is the HPLC graph, and in which you can see that there's a peak to peak. And it is 11%. And just now someone of you told me that less than 10% or 6%, you should not take it lightly. So now, what is your diagnosis? Especially now, we could not. Yes, very well. So, very good. Because my residents were discussing and they were very excited about P2 peak, and maybe they were thinking about all these diagnosis, but they are not common in India. So we should not consider them first. So we just, in fact, my technician said that, ma'am, I think we should rule out diabetes in this case. I said, call the patient. And we called the patient, we did his blood sugar, it was 200 plus, and he didn't know about it. And that is how then we picked up that this was a glycosylated hemoglobin. So when you're looking at HPLC, it gives you a lot of information, and you should all look at so many factors before labeling a patient into a particular hemoglobinopathy. So that brings me to the end of this talk. Thank you so much. So now, Dr. Pranta.
Yeah, thank you. Thank you, for discussing it extensively. And I think the students should be very, very clearly listening to what was being said, because I'll come to the disease which is prevalent in my part of the country where I used to live, that is hemoglobin E, right? So that is one thing which you'll get now all over India, because Bengalis are there all over, and even Assamese, Tripura people, they are there. And I have a googly for the students before I hand it over. If your A2 was showing something like 107%, what would you think? Do you think the HPLC is okay, or there is a machine error? Have you ever seen an HPLC with 107%? Anyone? Any student? Yes? Yes or no? You have to answer something. Come on. Have you seen A2 107%?
No, sir.
No, sir.
No. Okay. If you see it, what will be your interpretation? Yes, because madam showed you the table, right? And see, these are area under the curve. So can it be more than 100? And this is, I'm talking of an HPLC on a variant 2. So can it be more than 100%? Any idea? So let me tell you that, if you are using this kind of automated HPLCs which use calibrators, they have a calibration for A2 and F. So calibration wise, it can be more than 100. And that is seen in hemoglobin E disease, because they are not giving you the area under the curve of the entire percentage, which should add to 100. So when you look at the HPLC, if you add them up, most of the time they can be more than 100, but don't get alarmed by it. It is a normal phenomena because these curves are calibrated. Okay. So that is the technology, the chemistry behind this type of automation. Automation sometimes leads to this kind of solutions. Okay. Thank you, Mrinalini. Once again, I think
Thank you so
most
much.
of them will never see a hemoglobin electrophoresis. The way those technicians are vanishing, no one is now interested in doing it. But some people are doing capillary electrophoresis. But, agar-gel electrophoresis is an endangered species. So now over to the organizers, please.
Madam, there are a few questions coming up. Shall I
Yes.
forward? For how long we should incubate in HPH for golf ball?
Oh,
How
30
long?
minutes to 1 hour. We do 1 hour.
Okay. Then,
So hold on, Prantar, you're muted. Prantar, there is a question by Ifat. She says she could not get it. Beyond 100%, how is it? Can you just explain it slowly?
Yeah, I'll explain it once again. See, normally when you do a chromatography, that is what the chemists do in an open system. It gives you area under the curve, and all the peaks should add up to 100%, right? So those who are in pharmacology, those who look at drug levels using HPLC and others, they will never get a value more than 100%. But when you are doing hemoglobin HPLC, especially using an automated closed system like variant 2, it is not area under the curve, and those will not add up to 100% because it is giving you a relative value with response to the calibrator. So there are two things which appear here. One is that any value, like even F can be more than 100%, A2 can be more than 100%. Okay, remember this. And another thing is sometimes the retention time is not sacrosanct because by chromatographic principles, if some peak which is not very high is high, the retention time is advanced. So when you have an automated system, it tries to calculate, but sometimes if the hemoglobin F is very high, you will see that the system does not recognize the hemoglobin F peak as hemoglobin F, and it can give you an unknown peak, right? So was I clear about why it could be more than 100? Because it is comparing with the A2. A2 has been given a value. So when you run all these samples, I don't know whether you have run it personally, you'll see you have to run a priming and you have to run a calibrator before you start testing the samples.
Okay, sir. There's another question coming up. Sometimes HbA in sickle cell trait case shows HbA more than 50%, HbS around 40%, but raised HbA2 more than 4%. How to report such case, whether as sickle cell or heterozygous? Whether sickle cell heterozygous?
So I did not get the percentages. What percentages are you talking about?
I think values HbA 50%, HbS 40%, but HbA2 is more than 4%. So how to report?
Okay, so sometimes glycosylated HbS elutes in HbA2. So it also gives a slightly increased value of A2. So that is why always it is a tricky thing, and we in this case particularly we will report it as heterozygous HbS.
Then how to differentiate between HPHF trait and delta beta thal trait on HbS?
So again, it comes to the same thing, case-based approach. So delta beta is a symptomatic thalassemia. HbF is a asymptomatic thalassemia. So it begins, the whole story begins from how the patient has come. And then you look at the CBC, and delta beta will have a microcytic hypochromic anemia, and HbF will not have a microcytic anemia. Then we can also do a Klehor's test to see for the distribution, but that also many centers don't do. And you see for a pancellular or a heterocellular distribution, but just on these two things, that how the patient is presented and what is the CBC parameters, you will be able to differentiate between a trait, delta beta, and a hereditary persistence.
Then one question, do beta thal trait come under NTDT?
Do beta thalassemia what?
Do beta thal trait come under NTDT, non-transfusion dependent? I think so.
So it is not a hemolytic anemia, it is just heterozygous beta thalassemia. So NTDT, non-transfusion dependent, mostly will be which are sporadic and thal intermediates, and transfusion dependent will be beta thalassemia majors and beta thalassemia intermedia. And yes, NTDT would be a heterozygous. You're right.
Then Dr. Manoj has asked, Madam, can you...
Dr. Pranta, can you add to it? Because
Sorry, the question that
Hello, Dr. Pranta.
patient is behaving like an intermediate or non-transfusion dependent thalassemia.
Thal trait, no?
Remember that thalassemia occurs because concentration alpha and beta chains. So if there is a beta thalassemia, alpha genes, which so if there are excess alpha genes, then they can behave as non-transcriptional. And if you look for alpha gene, at least deletions in our country, you'll be able to make a proper diagnosis. So, based on the HPLC, you'll not be able to differentiate. Clinically, you can write that beta thalassemia carrier behaving as LGB. I think that clarifies the question.
Then,
Thank you. Aparna, you can proceed.
then somebody has asked, can you please repeat the basics of normal HPLC, normal area under curve?
That'll,
We can get, no, madam?
yeah.
Yeah, I think we'll keep the
Yes,
slides
yes.
on the replay. Yeah, replay link. Yeah.
Replay they can get. I think questions are over. Oh, questions are over.
I think students, do you have any questions from our teachers? Vineet, I didn't see you. You're gone. So anyone, Vineet or others, Vaibhav, you have any questions, Shraddha, for teachers? Or you are fine? You're all fine?
Did you enjoy it? Yeah, did you enjoy it? That is the most important question.
Yes, sir.
Excellent. I think Pranta, it was excellent by Dr. Mrinalini and then added tips by you. Students are lucky to have both of you. Mrinalini, you have any final comments for students which you think you missed out? You want to briefly tell them something? And similarly, Pranta, I'll come to you later. First, Dr. Mrinalini.
I have, sir, just one thing to say that nothing can be reported in isolation. And I have repeated in my talk again and again that the diagnosis of hemoglobinopathy starts from the clinical presentation in the patient. So one should never, ever not think about it. And clinical presentation and then history of blood transfusion are two very important inputs for correct interpretation. And then finally, when you have made a diagnosis and there is slightest doubt in your mind, always go for a parental screening. You should screen for the HPLC in both parents to come, and there can be some variations and some discrepancies that will be sorted out when you are doing the workup of parents. So if you are doing the first two things and the last one correctly, so the HPLC interpretation will be more authentic. And it is a very important document for the patient because that is a label which will be with the patient for the rest of the life. So it has to be written with lot of understanding.
Thank
So
you.
I need to say that.
Thank you. Prantar, anything you would like to final comments? You're
Yeah,
muted.
I think I would like to tell the students that they should be more challenging types, right? Dr. Mrinalini did not present certain data in the CBCs, like RDW was not present in all the CBCs. And none of you asked for it. Now, see, it is most important that you challenge us so that we can learn from you. So this is my final comment.
Yeah, I agree with you.
Yeah, Miss. Thank you very much, Prantar. Aparna, you have any comments or any questions?
Madam, is there any time period between the transfusion and interpretation of HPLC? Minimum time period? Or...
So we say, okay, 3 weeks. But the point is that the first HPLC before the transfusion is the most accurate one. When the patient has come to a hemolytic anemia workup and pediatricians are thinking that it is a hemolytic, it is the best time to do a HPLC because once you start with the transfusion, the values are always a little altered, but 3 weeks is still a reasonable time because sometimes this ideal situation doesn't happen. So at least 3 weeks difference should be there.
Thank you.
You have any, Prashant? Any comments or questions?
No, sir.
So I think if